South London and Maudsley NHS Foundation Trust and the Maudsley Digital Lab would like to provide you with an interview from our leading eating disorders expert, Dr. Hubertus Himmerich, as part of the Eating Disorders Awareness Week. We are currently developing an eating disorders virtual reality application under the guidance and research of Dr. Himmerich. This application will soon be made available to the NHS and the public via our App Store. Enjoy.
Hi, Hubertus. Lovely to chat with you. Really appreciate you making the time. So as it is Eating Disorder Awareness Week, I wanted to have a brief conversation about your work in eating disorders and the role that technology can play in helping patients navigate some of the challenges that they're facing. So can you tell me a little bit more about the work that you're currently doing with eating disorders?
Yes, sure. I'm a clinical senior lecturer for eating disorders at King's College London, and I do my clinical work as a consultant psychiatrist on an inpatient ward for patients with anorexia nervosa at the Bethlehem Royal Hospital. Working in an inpatient environment means that we can offer a very intensive treatment to people, and that includes meal support, but it can also include support with the urge to exercise. So my work is mainly with people who suffer from anorexia nervosa.
Gotcha. And what made you want to specialize in anorexia? Because I know that there's several different eating disorders out there. Why the focus on anorexia?
Well, I did my specialty training at the Max Planck Institute of Psychiatry in Munich, and during that time I was quite stunned by people who gained a lot of weight during treatment with antipsychotics. And my first consultant psychiatrist post was on the ward for patients with eating disorders and personality disorders at the University Hospital of Aachen. And I find it very interesting and rewarding to work with people who suffer from eating disorders. And before I came to King's College London in 2015, I was a professor for neurobiology of affective disorders in Leipzig, and I worked with patients who had obesity and depression. And therefore, it's very interesting to work with people on both sides of the spectrum, those who are very slim, like patients with anorexia, and also people who have the urge to eat constantly and do not exercise as much, like people with obesity. So I find this is a very interesting area to think about appetite regulation and physical exercise and how that affects mental health, and also how your psyche and mental health affects how much you are eating and exercising.
Interesting. And what do you believe are some of like the underlying mechanisms behind the eating disorders?
Yeah, so there are factors outside our body, like, for example, the environment. There's the social environment with the socio-economic status, culture, lifestyle, and a certain ideal of beauty. For example, in our society, being slim is the current ideal of beauty. But there's also the physical environment, like the built environment, whether you live in a city or in a more rural area. And there are nutritional factors like the diet and the nutrients in the diets, medication you use, for example, or probiotics. So these were the factors outside our body. And then there are factors within our body, like, for example, the gut microbiota, which bacteria live in our gut, and the regulatory systems of the body, the metabolic and endocrine system, the immune system. We have learned that messenger molecules of the immune systems, the so-called cytokines, have a specific effect on appetite regulation. And there's, of course, the brain as the major regulatory system of the body. And within the brain, we have the self-regulatory system and the hedonic system. The hedonic system is also called the reward system. So if we eat, for example, on a birthday party, we find that quite rewarding and pleasant. And this is this gives us reward and pleasure when we eat. And then we have the homeostatic system in the brain that makes sure that we have enough food intake and enough calories. But also the self-regulatory system, which I mentioned first, is quite important because we also eat to regulate our mood. For example, if we are depressed, we eat a lot of chocolate, or some people eat chocolate, or some people restrict completely. And other factors are consequences of the eating disorder, really. So if you have already changed your motivation to eat and your thoughts, and if you are malnourished, then the structure of the brain changes, and that makes eating disorder so entrenched because the changes in your body and the brain, they keep the eating disorder going. Yeah, maybe I should talk a bit about the various the different eating disorders to explain this a bit further.
I think that could be really helpful, because I think, like, for example, with anorexia and the restriction to not eat is probably very different from bulimia, where you can sort of overeat and then react to that. So
yeah,
yes,
absolutely.
I think an overview would be really helpful.
Mm-hmm. Yeah, this is really a spectrum of eating disorders, with the restrictive pole on the one side with anorexia nervosa, and binge eating disorder on the other side, where people overeat because they have binge eating episodes. Yeah, so anorexia nervosa is characterized by significantly low body weight and an intense fear of weight gain. And people also have a disturbed body perception. They think they are quite big, even though they are really tiny and small. Now, the prevalence is about 1% among women, and there's a sex ratio of 1 to 10. So only one man. The sex ratio means that 1% of women and 0.1% of men are affected by anorexia nervosa.
Quick question. So I've been seeing that the rates for men with anorexia are beginning to increase. What are some of the reasons that you think that might be?
Well, it might be that this is a real increase, and this might be due to the isolation we had during the pandemic, due to the fluctuation and the fluctuation in how people perceive their gender roles or sex roles. And it might also be the case that men are now more encouraged to talk about their eating problems, as it was so unthinkable for men to have an eating disorder, as it's so attributed to the female gender. Men were ashamed to even let others know about their eating problems, and this might be a kind of artificial increase. It may well be that men had a higher prevalence of eating disorders in the past, but they are now coming out with this problem. And I know that it's particularly hard for men, and as men have a bit more muscle mass by nature, it's harder for them to fulfill the criteria of anorexia nervosa, and that means men come into the service at a much later time point than women. Yeah. So this is an important aspect of our work, to think about the sex differences
Mhm.
and the gender of patients. Yeah, then with bulimia nervosa, the prevalence is about 1 to 2% with a similar sex ratio, and this is characterized by recurrent binge eating episodes and additional compensatory behaviors, like, for example, vomiting or excessive physical exercise. And the self-evaluation of patients with bulimia nervosa is unduly influenced by body weight and shape. And the third main eating disorder is binge eating disorder. About 3% of the population suffer from it. And if you suffer from binge eating disorder, you have the binge eating episodes, but you don't apply extreme compensatory strategies, which means that people usually gain quite a lot of weight over time. And they are embarrassed, and they also feel disgusted by themselves and guilty for not being able to deal with these urges to eat. The DSM-5, that's the Diagnostic and Statistical Manual for Mental Disorders, also acknowledges 3 further eating disorders: avoidant restrictive food intake disorder. This is when people have a restrictive eating pattern and avoidance of certain food groups, but they do not necessarily have the disturbed body perception. Then there's pica, which we can see usually in young children. This is the consumption of non-nutritive and non-food substances. And we have rumination disorder, where we see repeated regurgitation of food, and the regurgitated food might be rechewed or swallowed or spit out. So these are the 6 eating disorders in the DSM-5: anorexia, bulimia, binge eating disorder, avoidant restrictive food intake disorder, pica, and rumination disorder.
Gotcha. I heard that there was also one with diabetic patients
Mm-hmm.
around
Yeah.
insulin.
Yes. In young female patients with type 1 diabetes, the problem is that the insulin might lead to weight gain, and that raises a lot of body concerns in this population. And then they try to restrict what they are eating, or they do not inject the insulin in order to avoid the weight gain. And that can lead to serious health consequences. For example, retinopathy or problems with the kidneys, all the consequences that people with type 1 diabetes usually develop much later in life can be developed in these patients when they are in their 20s. So this is a really important medical problem, the type 1 diabetes plus disturbed eating.
Gotcha. And I'm sure it must be difficult to treat patients with these conditions, especially if, as you're saying, some of the behaviors become a bit entrenched. I'm sure if you tell a very skinny patient with anorexia that the treatment will make them gain weight, they can be really, really resistant to that idea. What are some of the treatments that are currently used, or I guess there's some treatments that were previously used for patients with eating disorders?
Yeah, so currently the main pillars of treatment of eating disorders are psychotherapy, then the dietary treatment, and physical health monitoring. Some patients need additional treatment with medications. For example, people use olanzapine, which is an antipsychotic with a side effect of weight gain and also beneficial effects regarding sleep and concentration. But this has not been approved for anorexia. And in bulimia nervosa, we we can use fluoxetine, which is an antidepressant, and in the United States, lisdexamfetamine, which is a medication for attention deficit hyperactivity disorder, has been successfully tested and approved for binge eating disorder. There are also different treatment settings I would like to mention. First, there's usually an assessment in outpatients, and in outpatients they can offer like weekly appointments for psychotherapy and physical health monitoring. Then there's day care. That means that patients come in the morning and leave in the afternoon, and inpatient treatment, where I work, which is the most intensive form of the treatment. Additional therapies that are more and more used or more and more like valued are occupational therapy, creative arts therapy, and active or receptive music therapy. For example, we have a kind of choir on our ward where we sing with our patients. They can choose the songs and explain what these songs mean for them. But there's also receptive music therapy possible, or people can create their own playlists for certain difficult situations in life. So I think it's important to combine therapies. Psychotherapy is, of course, the main treatment, but we need the dietitians, we need the psychiatrists and the medical doctors, and it would also be desirable because these therapies are so helpful to combine this with creative therapies.
Definitely, yeah, because I think with some of the therapies, making sure that you're treating sort of the emotions of the patient as well as their physical health sounds really, really important. And I know that you've been leading on some digital therapies as well, including virtual reality. Mm-hmm. So what made you consider using virtual reality to treat patients with eating disorders?
Mm-hmm. Yeah, virtual reality has a lot of advantages because some people cannot do the exposure or cannot deal with food in the real world, and virtual reality might therefore be an intermediate step. Virtual reality has been used in several ways already in the recent past. For example, patients can be exposed to different body shapes in virtual reality, and you can work with a general body shape in general or their own body shape. And you can also do exposure therapy with exposure to different types of food or amounts of food in VR. You can include relaxation or distraction into a virtual reality application. And the latest development I've heard of is that Valentina Cardi, who was a researcher at King's College London, and Janet Treasure, who is a professor currently at King's College, they tried positive mood induction during virtual reality. In their paradigm, they chose a pink elephant that appears during a VR session and brightens people's mood. So you can do a lot of things in virtual reality. And another advantage is research, because you can register people's behavior continuously. For example, every gaze at a certain food type or every interaction with food can be documented. And that's also a nice clinical application, because you can analyze the therapeutic process in much more detail in VR psychotherapy than you could do it in reality.
Gotcha. Interesting.
Yeah.
And I think with the exposure therapy, that sounds definitely really useful. I've heard of it being used for patients with other phobias as well.
Yeah.
And can you tell a little bit about about some of the projects that you're currently working on with virtual reality?
Yeah, so we are currently developing a VR application together with Maudsley Digital and SyncVR, where we use a paradigm where we combine relaxation and distraction. And this can, for example, be used after a main meal. After main meals, patients are usually very upset about the amount of food and the calories that they've just eaten. And an additional challenge in an inpatient setting is that they have a rest period after meals. And this takes place in the communal lounge and makes sure that patients don't exercise excessively after a meal or do not vomit to get rid of the calories. And in this very tense situation, I assume this VR application can help a lot, because people can distract themselves by doing things like watering flowers during the VR session, or they can just sit there on a bench and listen to some music. We have identified specific pieces of music composed by modern classical composers that can help people relax. And that means people can do something, distract themselves, get some relaxation, even if they have to stay on the ward during the time after meals. So I think this is a very, very promising project, and we'll see how it can help patients in the future.
Yeah. And I know that sometimes people say, well, why can't patients just look at their phone to be distracted? What do you think about VR can be beneficial for really providing that kind of distraction or immersion for patients?
Yeah, because in VR, people can immerse much more into the reality. They don't have the real world around them and the distractions from other patients. If they sit there with their phones, they can still see other patients struggling, hear unhelpful comments about their eating behavior or what they've just eaten or what they think. They can still have the TV running in front of them, potentially playing like music videos with objectifying pictures of the female body, etc. So VR is much more immersive, and therefore I believe that the treatment success would be much better than just having a smartphone app.
Gotcha. And what are some of your hopes for the future? What kind of future things would you want to see in VR for your patients?
Yeah, I think in the future we can combine even more aspects of therapy in virtual reality. For example, different psychotherapeutic techniques like exposure, positive mood induction, relaxation, receptive music therapy, or we can even combine it with active music therapy, like playing drums in VR. We can also introduce other technical features like avatars. Avatars could, for example, impersonate the eating disorder, or could serve as a digital therapist. And we could also combine VR with innovative medications, for example, ketamine or the psychedelic psilocybin, to enhance the treatment even more.
Amazing. Yeah, I think those sound like really, really exciting ideas. I know I've been hearing a lot about people looking into ketamine therapy in the future. Just out of curiosity, what do you think about I know this is slightly off topic, but what do you think about the use of like ketamine or psilocybin as more standard treatment approaches?
Yeah, currently one problem is that so many people with an eating disorder like anorexia nervosa suffer from depression as well. And the standard antidepressants do not work because they are serotonin reuptake inhibitors. And if there is no serotonin because people don't eat enough amino acids, then these medications don't work. But psilocybin and ketamine have different mechanisms. They don't need serotonin in order to activate the serotonin receptor. And that means they can induce a positive mood. And what does that mean in clinical practice? If your mood is low, if you don't have hope, you don't make plans for the future, and people think therapy is futile anyway, the therapy won't help. But if they can overcome this comorbid depression and they feel the energy again and they have hope again, this increases the chances of success during this therapy.
Yeah, agreed. That definitely sounds like a helpful thing. Amazing. Well, thank you for taking the time to speak with me. I really, really appreciate it. And we look forward with collaborating you on our VR projects.
No, thank you so much for inviting me to this interview.
Sure. Thank you. All right. I hope you have a good rest of your day.
Yeah, thank you very much. The same to you. Bye.
Thanks. Bye.